Ghoneim, who is currently running the telepsychiatry program for the Manhattan VA, outreaching around New York State I think you're predominantly treating severe and persistently mentally ill veterans.
A lot of PTSD, actually.
A lot of PTSD.
Yeah, which is the topic.
Yeah, which is the topic of today. So she's highly experienced and always a favorite speaker for the year. So we're always very grateful for your time and attention to our trainees. We have a bigger group than usual as we're in a virtual space. A lot of medical students, nursing students. I'm not sure if we have PA students today, and also the fellows, last but not least.
Very good.
Thank you for joining us.
No problem, no problem. All right, so today I'm going to be talking about PTSD in later life, and let me share my screen here. One second. There we go. Okay, almost there. Share. Okay, can everyone see the screen? Yeah, okay, good. So the topic today is PTSD in later life. So I think it's always helpful to go over the DSM-5 criteria for PTSD, just in case. It's just a good review. So the criteria include you have to have exposure to actual or threatened death, serious injury, or sexual violence, either by directly experiencing the traumatic event, witnessing it in person as it occurred to other people, or having it occur to a close family member or friend, in cases where it's like an actual threatened death of a family member or friend and it's violent or accidental. So that's one of the criteria that's required. There has to be presence of intrusion symptoms associated with the traumatic event. So things like nightmares, flashbacks, intrusive memories. There has to be avoidance of stimuli associated with the trauma. So I have a patient who was in a battle where it was snowing. So whenever it snows, he avoids that and he'll like stay indoors. That'd be an example. There have to be like negative alterations in cognition and mood. So they may not be able to remember the trauma very well. They may feel detached from other people. They may have they might not want to, anhedonia is quite prominent in a lot of these patients. They may not want to be involved in activities. And then the other requirement is an alteration in arousal and reactivity. So that'll be things like irritability, problem sleeping is extremely common, hypervigilance where, people will be watching the door. They're always sitting, so they're facing the door. Exaggerated startle response is very common. Reckless behavior can also be pretty common. So I have like a patient who, they will seek out very risky situations, like drive really fast and that sort of thing. So that's just a review of PTSD in all age groups. All right, so let's talk about the prevalence of PTSD, both in older adults and just the general population. So in the US population, the lifetime prevalence of PTSD is about 6.8% in all ages. So in adults over 60, the prevalence is 4.5%, and it's higher in women than in men. If you look at traumatized populations, the prevalence rates are much higher. So in Holocaust survivors and POWs, the prevalence rate is about 46 to 55% of patients will have PTSD, or who have gone through this experience will have PTSD even 50 years after the trauma. as in many other mental health disorders, the prevalence rates are often underreported in elderly patients for several reasons. Sometimes the symptoms are attributed to illness or aging. For example, if someone has trouble sleeping because of PTSD, it might be attributed to some sort of illness, you know, something like that. If there's also the increased stigma where, you know, patients won't seek out treatment or they won't want to talk about the trauma as much as younger patients perhaps might be willing to do so. And it's interesting, in older populations, there's a much larger group of patients who have sub-threshold criteria for PTSD. So they meet some of the criteria, but not all of the criteria. So in some cases, it's missed for that reason. Okay, so, all right, so there are several trajectories that PTSD can manifest, like how it can manifest itself in older adults. So one of the most common ways is like, you know, a chronic PTSD picture. So someone will experience a trauma in early life, and then they will develop PTSD soon after, and it's a chronic course, and then they will continue to have it in, you know, older age. Another potential trajectory is that some people will have a trauma early in life, and then it'll be like kind of quiescent, or just the symptoms are minimal for a long period of time. And then for whatever reason, once the patient reaches like 65, 70, they develop full-blown PTSD. So there's like a delayed onset PTSD. And then just like younger patients, you know, older patients might, you know, be okay. They might not have any trauma in early life, and then they experience some trauma when they're an older adult, and then they develop new onset PTSD. So in general, like most psychiatric disorders, PTSD is, you know, it's like it has a chronic course usually, but it like sort of waxes and wanes with stressors that occur in one's life. So, okay, if anyone has any questions, please go ahead and ask. All right. Okay, so let's talk about the new onset PTSD for older adults. So older adults can develop new onset PTSD just like younger adults can. It usually occurs, it can occur at the same rate or maybe a little bit lower rate than that younger adults do. And these prevalence rates come from studies of natural disasters and interpersonal violence. Just like younger patients, older adults have the same risk factors for developing PTSD. So if they have had an experience of childhood trauma, they're more likely to develop PTSD as an older adult. If they have like lower self-efficacy scores, so that means that they don't believe that their actions actually will have any bearing on their future, then they will also have a higher likelihood of developing PTSD. And if they have lower social supports, they will also have a higher likelihood for developing PTSD. So pretty similar to younger patients. So, and then let's talk about the chronic PTSD course. So this is the group of patients who experience a trauma in younger life, and then they develop PTSD, and it continues throughout their life into older age. So if you look at this study, this is a study of the percentage of community dwelling World War II POWs who reported being seriously troubled by PTSD over a period of time. So if you look at when they're the first year after discharge, there's a very high percentage of patients who are seriously troubled by PTSD symptoms. But as the time progresses, that percentage of patients decreases. However, if you start to look like 40 or 50 years after discharge, that percentage starts to go back up again. Not to what it was, you know, after the first years of discharge, but it's definitely, you know, a significant rise. So that brings up the question of, like, you know, the heterogeneous trajectories of chronic PTSD. There seems to be like a group of patients, about 28% of patients who develop a significant worsening of symptoms in older age. And the question is, why is that? And we'll come back to that question. And then there's like the other form of PTSD. There's a delayed, what we call the delayed onset PTSD, which is the one where there's a trauma in early life, but for whatever reason, like it's quiescent for a period of time, like the patient is functioning quite well. And then in older life, they start to develop full-blown PTSD. So this has been described in several case studies and case series, especially in populations of POWs and Holocaust survivors. There is some controversy about this type of PTSD because it's not well characterized. There aren't a lot of studies about it. But I can say in my own experience, treating these patients, I definitely see it. I see patients who have functioned quite well throughout their life, you know, after they've been to war, and then like in their 60s and 70s, they will develop the full-blown PTSD. So anecdotally, I think it's true. All right, so let's go back. Like, I would be interested in why do you think that in older age, some people might develop full-blown PTSD when they did not have it before, or they may start to develop worsening of their chronic PTSD? Does anyone have any guesses? Sure.
I do, but I'd like to hear if the students have any thoughts about it first. No. Well, one of the things that in some work that I did on adverse childhood experiences that get triggered later in life, there is some kind of a trigger. Something happens that sets off those same chemical and neural responses in the brain. That's a science that is beyond my most of my understanding, but I know that it occurs, that it is a physiologic response, if you will, that triggers then those behavioral and emotional responses. You know, and I put some things in the chat about, you know, defining the population that you were talking about. Is it, you know, is it everybody, or is it just, you know, sort of post-war people? And war may trigger some of the violence that they experience as children. And you know, I'm real interested in what happens in terms of people who have subjected to ACEs in their later life. Did they just have some resilience that they lost when they got older because of whatever reason? I think it's a pretty complex phenomenon.
It is a complex phenomenon, yeah. And there's several theories about, well, yeah, why that is. And one of them is that there's like a physiological phenomenon. So yeah, let's look at the theories. Okay, so.
Just one, I think.
Oh, go ahead.
Well, something like that cortisol level, which is a stress hormone, it decrease also with age. So maybe your ability to kind of be resilient, like Ghoneim was saying, it decreases your ability to fight stress. Decreases also because the cortisol level decreases as you age. Yeah.
I didn't read about that, but that makes sense. Yeah. I'll look into that more. But these are the theories that I came across. So one of the theories is that there is a disinhibition of neural pathways that occurs, whether like it's through the development like of vascular insults in the brain, or you know, the development of dementia perhaps, and that the thought is that the emotional and traumatic memories are perhaps stored in, you know, some subcortical regions of the brain, and that as some of the cortical regions of the brain become disinhibited or die off, that these, you know, traumatic memories become more prominent. So that's one theory I read about. Another one is that there are triggering reminders of the trauma in older age, that like as people age, they're more likely to be exposed to illness in themselves or in people they know, or they may be more likely to be exposed to medical facilities that may bring on, you know, some traumatic memories. So that's one theory. Another theory is that it's like normal you know, development, psychological development, that as one ages, we increasingly reminisce or reflect on our life, and that may prompt memories to, I don't know, more prominent memories or examination of those memories. And then another thought is a loss of, you know, social structures like retirement, loss of a spouse perhaps. So, you know, these important social structures in our lives. So these are some of them. I'll have to look at the cortisol response as a potential theory as well. Okay. And a note about dementia and PTSD. So it's, you know, it's kind of like a two-way street. So the onset of dementia can worsen PTSD. It also, PTSD can be associated with increased risk of cognitive impairment and dementia. So this graph right here is from a study that was completed in 2010, and it shows the cumulative incidence of dementia over a 7-year follow-up period in a large cohort of patients with and without PTSD. And this is in a study of US veterans. So in this group of patients, the patients who had PTSD had a twofold higher risk of developing dementia as compared to the patients who did not have PTSD. And this association was, you know, remained even after, you know, there were corrections made for, you know, comorbidities that often occur with people who have PTSD, like traumatic brain injuries, depression, and substance use. And also, like, you know, there was also correction for important differences like demographics as well. So, you know, again, like here, the thought is that like maybe perhaps patients with PTSD, you know, because they do have chronic stress, the stress may, you know, the acute stress may produce increases in cortisol levels. So here's the cortisol connection, and that hypercortisolemia is perhaps associated with increased risk of dementia. So that's one theory there. All right, so let's talk about the diagnosis of PTSD in older patients. You know, there are some special considerations you should take into account when making a diagnosis in your, you know, older patients. So, you know, like in most psychiatric conditions, older patients will present with increased somatic symptoms versus emotional or psychological symptoms. So they will often present with sleep problems, pain, appetite problems. They will usually present to primary care or urgent care. They may present with a new functional impairment, like, you know, the inability to do their bills or go shopping or something like that. In older patients, you may, you know, notice that they're complaining more about hyperarousal symptoms, like, you know, increased startle, irritability, as compared to the re-experiencing symptoms. So they usually don't talk as much about nightmares and flashbacks, especially if the trauma is experienced in later life. And cognitive impairments may interfere with the patient's ability to communicate and interpret their symptoms of PTSD. And like I said before, older adults are, you know, frequently experience symptoms at sub-threshold levels. So they may not meet the full criteria for PTSD, but it's still very distressing for them. And they're more likely to feel stigmatized. All right, so here's a summary of the different treatments that we have for PTSD, like sort of the treatment guidelines, and this is true for all age groups. So if you look at this table, it kind of shows the first-line treatments. So first-line treatments include psychotherapies like prolonged exposure therapy, cognitive processing therapy, and eye movement desensitization and reprocessing, which is known as EMDR. I'll like briefly explain what those are because I don't know if everyone's familiar with those types of therapies. So prolonged exposure is basically, it's a type of therapy where you talk about you know, the trauma that you underwent with your therapist, but you do it little by little. So you'll start with just talking about it very, you know, very limited details for a short period of time. It's supposed to cause a small amount of distress. And then you increase the amount of time and the amount of detail you talk about it with your therapist. And the idea is that over time, it will reduce the amount of distress that you feel when you have memories of this. And there's a lot of data to support this type of treatment. There's also cognitive processing therapy, which is basically a type of therapy where you know, address unrealistic thoughts and, you know, regarding the trauma. So this is often used for patients who have a lot of guilt, like moral guilt about, you know, their involvement in the traumatic incident. So that also has good data to support its use. And then there's EMDR, which is a type of therapy that I don't know if it's well explained about why it works or how it works, but basically it's a type of therapy where you will be taught to briefly focus on the trauma memory while at the same time you are experiencing bilateral stimulation. So usually that's like a dot that's moving back and forth. So you're looking at the dot that's moving back and forth while you are thinking about the traumatic event briefly. And for whatever reason, this seems to be associated with a reduction in the vividness and emotion associated with the trauma. Not clear how it works, but there is also good data for this. First line psychopharmacological treatments include SSRIs like sertraline, paroxetine, and fluoxetine. So that's what you will see being used most often. The second line treatments that have shown demonstrated benefit but don't have as much data to support them are CBT therapy specific for PTSD, narrative exposure therapy. So narrative exposure therapy is a type of therapy where you basically, you know, create a narrative where you contextualize traumatic memories in like your whole life story. And usually this has been this has been done with groups in a group format, and it's been shown to be very effective in refugee populations. And then there's the brief eclectic psychotherapy, which includes elements of cognitive behavioral therapy and psychodynamic therapy. So that has shown some benefit as well. Second line psychopharmacological treatments include venlafaxine, an SNRI, imipramine, a TCA, prazosin, which is used for nightmares and flashbacks. And then some treatments that have been shown to have some benefit, but like, you know, the studies just aren't very clear about how much benefit are meditation-based interventions and an antidepressant called nifazodone. So nifazodone is not really an antidepressant that we use much anymore. It's actually tried to order it for a patient recently. It's like coming off the market. So I don't think it's worth discussing in this setting. And then, you know, there are some treatments that guidelines recommend against using, like monotherapy with antipsychotics, benzodiazepines, and medical marijuana. At this point, we don't have enough data to support its use. And then there are experimental therapies. So we'll discuss those more in detail.
So quick question, if that's okay.
Sure.
I guess I often think of paroxetine as kind of something to be avoided in older adults.
Yeah.
Because of the anticholinergic activity. Maybe you're going to talk about that on, sorry.
I will talk about that. Yeah.
Oh, sorry.
This is basically a treatment guidelines for all age groups. They just sort of wanted to like put a summary. Sertraline and paroxetine are like the only medications that are FDA approved for, or the two SSRIs that are FDA approved for PTSD. But that just because they're the only ones who sought approval, it's likely that all SSRIs are just as effective. So yeah, in older adults, you will probably not want to use paroxetine, and I'll come to that. I'll talk about that a little bit more.
Thank you. Sorry to get ahead of you.
That's all right. Okay. So let's just talk about what information we have specifically for treatments in later life. So unfortunately, we don't have very much information that's specifically for older adults. So there are a few interventions that have been tested specifically in older adults, because few older adults are accepted into randomized controlled trials. Usually there isn't like a subgroup analysis, there aren't enough patients to do that. And as a result, there are no actual practice guidelines for patients who have PTSD but are older and who are 65 years or older. However, we also don't have evidence that the treatments that are effective in younger adults are not effective in older adults. So generally, we do similar things for both populations, with some exceptions, which I will talk about. Okay, so when you prescribe psychotherapy in older adults, there might be some things you might want to think about that you might not think about for younger patients. So you're going to be wanting to think about, does the patient have the ability to participate in cognitive type therapies? Like, so do they have the requisite cognitive abilities? So there is one small study that indicated that poor verbal memory was associated with non-response to cognitive behavioral therapy, which makes sense. And the other thing that some people have expressed concern about is whether prolonged exposure therapy is safe, because it's associated with, like, you want some hyperarousal when you're doing that type of treatment. So some people have said, like, is it safe for patients who have like cardiac conditions, severe cardiac conditions? I don't think there's any evidence to say that it isn't safe, but that is a concern that is expressed in some papers. There are some smaller studies that indicate that psychotherapy is effective in older patients. So there's one study of 145 sexual assault survivors, women greater than 65 years old, who did respond well to psychotherapy. They responded better with prolonged exposure therapy versus cognitive processing therapy. There's a very small study that was done on 11 older male veterans, which showed that prolonged exposure was safe and effective. And then there really aren't any randomized control trials, but there are randomized control trials for depression and generalized anxiety disorder that indicate that cognitive behavioral therapy is effective in older patients. So we assume that it would be effective for PTSD as well. So some tips for conducting psychotherapy in older adults. You want to have a consistent structure through each session of therapy. You want to summarize frequently, and you want to use multiple learning modalities like written materials, video materials, tape materials, just to get around the potential for cognitive or memory deficits. Okay, so now let's talk about using medications in older adults who have PTSD. So again, there's limited data on the efficacy and safety of drugs in late life PTSD. Again, older adults are not typically included in medication trials, and those that are included are usually the healthiest patients. So we just, when you're treating these patients, you just want to keep in mind the general pharmacotherapy recommendations in older adults. So you want to start low and go slow. So think about starting at half the dose you normally would with younger patients and increasing at half the rate you normally would. You want to check their kidney and liver function. You want to make one change at a time, and you want to do medication teaching to both the patient and their caregiver if there is like a caregiver involved. All right, so the first line pharmacotherapy for PTSD is SSRIs. So again, paroxetine and sertraline are the FDA approved treatments for PTSD, but again, most SSRIs are probably just as effective. There's caution, we probably don't want to use paroxetine because it has anticholinergic side effects. And you also want to be careful with fluoxetine because of its long half-life and its potential for more drug-drug interactions. So usually the typical first choice in my practice is sertraline, and I think it's true for most psychiatrists as well. All right. And then a second line treatment would be an SNRI. Venlafaxine has been shown to be effective in clinical trials for PTSD. Again, we have no data for older adults, but in studies of geriatric depression, the side effects in older patients were pretty similar to what was seen in younger patients. All right, so let's talk about prazosin in older adults. So prazosin is an alpha-1 adrenergic antagonist. It is used for typically for nightmares and PTSD and just like sleep issues in general. It can be helpful. But studies are mixed in regards to its effectiveness. So, there are some small studies that were shown that, have been shown to, they've demonstrated like significant efficacy for prazosin, but then there was this really large randomized control trial. It was a VA Department of Defense study that showed that there was no significant benefit with prazosin. So right now it's kind of like a second line treatment. So there was a study, a very small study, open label study of 9 patients with PTSD with a mean age of 76. They used 2 to 4 milligrams of prazosin, and 8 out of 9 of those patients experienced a greater than 50% reduction in nightmares. Again, this is open labels, very small number of patients. Usually it has minimal side effects. You just have to be, concerned about, the blood pressure being too low or transient lightheadedness. So I usually tell patients to get up slowly from bed in the morning. You don't want to get up quickly. And with older patients, you probably don't want to use the really high doses. So I can use up to 8 milligrams in younger patients, but in older patients, I usually don't go higher than 4 milligrams. All right, so tricyclic antidepressants. There is evidence for their use in geriatric depression. It has not been well studied in geriatric PTSD. There are concerns about the use of tricyclics in older adults because they have anticholinergic, antihistaminergic effects like cognitive impairment, falls, hypotension. So usually they're a 3rd or 4th line choice. It's best if they're avoided. And then there is the use of atypical antipsychotics in PTSD. So if you look at the guidelines that chart that I showed you, it kind of recommended against the use of atypical antipsychotics. However, if you look at what people actually do in real life, you'll see that they are actually frequently used as adjunctive treatments, either as adjunctive treatment or as monotherapy in non-responsive patients who don't respond to the SSRIs and the SNRIs. The guideline, says it is better not to use it because there was a randomized control trial that showed no benefit of risperidol as a monotherapy for PTSD in younger patients. However, we still use it because sometimes patients, symptoms might be so severe and they're not responding to any medication. So we'll try that. And anecdotally, I can say it's effective in my practice at times, not for everyone, but for some people. So often I'll use quetiapine or something like that. But you do have to be really careful in older patients because or just in all patients actually, but especially in older patients because of the metabolic side effects and the greater incidence of mortality in patients with dementia and cognitive impairments. All right, so sleep is often very impaired in PTSD. It's one of the symptoms that people most complain about. So some of the things we can do to target sleep are mirtazapine, which can sometimes be helpful for sleep and appetite and has potential benefit in PTSD. There are some behavior and non-drug therapies that can be helpful, like sleep hygiene, light therapy, like using a light box in the morning, increasing daytime activities, physical activity in the daytime, and then CBTI, or cognitive behavioral therapy for insomnia, can be helpful for people with PTSD as well. The general guideline is to avoid benzodiazepines because there has been no efficacy found in PTSD in studies. And there's evidence that it could actually hurt, it could actually like make the treatment ineffective if that patient is undergoing prolonged exposure therapy. So it might interfere with the habituation and learning and psychotherapy. It can also be dangerous in older adults. It can be associated with cognitive impairment and paradoxical agitation. And generally, I try to avoid Ambien too in patients with PTSD because it can actually cause worsened nightmares in a subgroup of people. All right, and I thought I would include a slide about experimental treatments as well, just because I think that's always interesting to see what's on the horizon. So what is being studied currently is how mindfulness and meditation might be helpful for PTSD. So far, the studies have shown small incremental improvements in PTSD. There's also studies of MDMA-assisted psychotherapy. So basically, this would mean the patient would be taking a small dose of an MDMA drug, and then that would supposedly assist in the psychotherapy process by facilitating traumatic memories without the user feeling overwhelmed by the negative affect caused by those memories. So that type of treatment has undergone phase 1 and phase 2 studies, and it is now in phase 3 clinical trials. So if the FDA has granted it a breakthrough therapy designation. A lot of my patients ask me about cannabinoids and marijuana and the treatment of PTSD. They all want they all want that treatment. So what I tell them is that we don't have enough data right now. So it may hold promise as a treatment for PTSD. For example, CBD has been shown to help with depression and anxiety acutely. And THC may reduce nightmares and insomnia in a small study, but the evidence is limited at this time, and all the studies are low in quality with many limitations. So it's very difficult to study because of the legal restrictions. Currently, the APA recommends against its use. So that's what I tell my patients, is that there isn't enough evidence at this time to support any clinical recommendations about it. And then there's also the treatment called a stellate ganglion block. And this is basically an injection into the stellate ganglion at the base of the neck. And this has been used as a pain treatment by anesthesiologists for many years. And it has intermittently been used for PTSD since the 2010s, just through anecdotal evidence. In November 2019, the results of a randomized control trial were released, and they found a significant reduction in PTSD symptoms, roughly double the improvement of the placebo group. So that is a potential treatment on the horizon that, is starting to be used more as well. And the thought is that it might be helping with reducing hyperarousal and the fight or flight response. So those are some of the new horizon treatments. All right, and that's all I've got. Does anyone have any questions?
Hi, this is Shirley. I'll raise an issue if no one else has one, because I'm really interested in the impact of ACEs on older adults and the relationship of ACEs and social determinants, as they're pretty closely tied together, and whether or not you find people who, I mean, you know, think about all of the treatments, but whether you have some sense about the resiliency in older adults. I had to go off and take a phone call, so maybe I missed that part of the discussion, but there's a lot in the literature about ACEs and about resiliency, especially in older life. And I was wondering if what you observed in your practice in relation to that, if you had any observations about that and the social determinants.
So I would say, like, I have a proportion of my patients who do seem very resilient, like, because they've been through some trauma, they seem to be better able to cope with further traumas. But then I also have that, like what we discussed in my earlier slides, where there's that group of patients who seem to actually be primed for developing worsening of PTSD with increased stressors as they age. So I don't know, I don't know how to differentiate between those two groups. Do you have, with your readings, have you been able to figure out what the difference is between those two groups?
Well, I'm not much of an expert. I'm a real dabbler in this area, and I've been looking at some of the issues in relation to students and this kind of trauma, and following some of the trauma, what do they call it? Environments that are trauma friendly. That's a bad word, but that address the issues. So haven't thought about it much in a patient therapeutic sort of way, more sort of groups of people and how they respond, and what we can do as providers to get people to be able to deal with some of those issues. But and I don't know that the literature is definitive about what makes somebody resilient. We don't really understand a lot of that, except it's about a lot about support systems.
Yeah, social supports and childhood trauma.
And I was struck by some of the things that you said about how these would occur, in people who are much older. It's almost like, and I don't think there's a lot of study about ACEs and older adults, but certainly lends itself to some exploration, because many of the factors that contribute to the trauma, they have multiple factors, because they're losing their supports, they're isolated, they don't have it. So all of those things that contribute to it can be there for many older people. And it's also be interesting, I'm sure somebody must be studying this, about what in this era of this pandemic, what both the short and the long-term impacts of this are going to be relative to trauma and people's responses physiologically to trauma. So it's a huge area.
I can tell you anecdotally that, like, a lot of my patients, older patients who have PTSD in the pandemic, will tell me, I'm ready for this. Like, this isn't something that's getting me down, because like I've been practicing for this my whole life. Like, I've been withdrawing and isolating my whole life, and also, like, I've always been prepared for a disaster. So a lot of my patients seem to be doing surprisingly well with the pandemic. I do think there's a population that definitely is not doing well. And I'm sure we'll see that in healthcare workers and
yeah.
Any other questions?
Thank you.
Okay. All right. Thank you, everybody. I hope you learned something. and I'll be back next week. So we'll talk about anxiety disorders next week.
Okay. Okay. Thank you.
Thank you. Thank you so much. My kids are having a moment, and I was running in and out of the room. I'm sorry that I didn't get to interact a little more, but thank you so much for your time and for an excellent talk.
No problem. No problem. Bye, everybody.
Thank you.
Bye.
Bye.